and that is a important and less practice session, we assume. It is a proning the patient in ICU. Hand over to team.
Namaskar, I am Dr. Mamta, Assistant Professor, Anesthesia Department. In this scenario, we have a patient who is on mechanical ventilation. Despite optimal ventilatory setting, patient is not maintaining oxygen saturation. So the clinician has decided to put the patient prone. Team member, kindly introduce yourself first.
Good afternoon. My name is Dr. Yawar Rashid. I am an assistant professor in the Department of Anesthesia.
Good afternoon. My name is nursing officer in ICU. Good afternoon. Good afternoon. My name is Kuldeep Singh. I am promoting.
Good afternoon. Myself Kumari, nursing officer.
And
Nursing officer.
So before proning the patient, we have to think few things before proning the patient. So the maximum patient safety is there. The patient should first have the arterial line and central line in place before proning. Central line should be so priority should be given to the internal jugular venous catheter line. But if femoral catheter is already there in place, then we should fix it over there so that it doesn't get kinked or pulled out during the procedure. And all the lines below the waist will be pointing towards the footing of the bed. All the lines above the waist will be pointing towards the heading of the bed. If the patient is already having the Foley's catheter, then it should be fixed on the posterolateral aspect of the thigh. Patient should not be given feed 2 hours prior to the planned procedure or proning maneuver. If patient has been given feed already, then it should be suctioned with the Ryle's tube and the stomach should be emptied. Then we should start the procedure. Before starting the maneuver, we should put the ventilator setting FiO2 100% and then check for the hemodynamic stability. Patient should be hemodynamically stable. Now we will start the maneuver. First take one bed sheet and put it on the side of the bed, on the ventilator side of the bed.
It's very important to have adequate personnel with us. So before going for things, we need to have team which consists of 3 personnel on the left, 3 personnel on the right, and 1 respiratory person for the head end to take control of airway.
Now the team opposite side of the ventilator will pull the patient upward at the angle of 45 degree.
Securing the airway.
And the team on the ventilator side will push the bedsheet in. Now make the patient supine. Dr. Rashid will take care of the tube, endotracheal tube and the IV lines.
On the count of 3. 1, 2, and 3.
Make the patient supine.
No.
Now the team opposite to the ventilator, turn the patient towards the ventilator and spread the bedsheet across.
On the count of 3. 1, 2, 3. Turn the patient towards the ventilator.
At an angle of 45 degree. Check for the tube and the IV lines.
IV lines and tube is secured.
Now make the patient supine.
On the count of 3. 1, 2, 3. Make the patient supine.
Now take another bedsheet and place it over the patient.
Spread it over the patient. There should be no wrinkles.
Bedsheet should be wrinkle free and it should lie flat on the patient. Now take one pillow and place it over the chest of the patient. One pillow over the hip of the patient. 2 pillows over the shin of the patient. Now take another bed sheet and spread it over the pillows. Please ensure the bed sheet is wrinkle free. Now the team on the ventilator side will grab all the 3 bed sheets and will roll inward. Now opposite team will grab all the 3 bed sheets and roll it outward. Now the team opposite to the ventilator will slide the patient towards themselves.
On the count of 3, 1, 2, 3, slide.
Now the Dr. Rashid will check for the ET tube position and IV lines.
ET tube is secured. There is no kink in the tube, and IV lines are secured. On the count
Now
of
make the patient semi-prone. On count of 3, Dr. Rashid will count.
on the count of 3, 1, 2, 3.
Make the patient semi-prone. Check for the tube position, IV lines and patient position. Team will check for patient position.
Tube is secured. IV lines are secured.
Now on count of 3, turn the patient prone.
On the count of 3, 1, 2, 3. Turn the patient prone. नीचे हाथ नीचे हाथ ले नीचे.
Please check for the position of pillows and the patient proper positioning. Dr. Rashid, please check for the tube position and IV lines.
IV lines and tube are secured, ma'am. There is no kink.
Now take one pillow,
Head.
one bed sheet and make it a roll and place it under the neck.
Placing the bed sheet under the neck.
Now place the patient in reverse Trendelenburg position. Head should be towards the ventilator side. Make it reverse Trendelenburg. Every 2 hours, head position of the patient should be changed. Remove the top bed sheet from the patient.
Check for the pillows.
Pressure bandage should be applied as per the pressure point map.
Pillows पे खींचो.
RT feed can be started after 2 hours of proning, and IV line and tube position should be checked after the proning position. Now the hand position can be changed. The right hand can be placed in swimmer's position. Rotate it gently and place the palm.
This is not possible, and this won't happen in the mannequin.
Rotate gently and then we can place the palm facing downward on the bed near the head. Now after 2 hours, we have to change the patient's head position. So take one bed sheet and spread it across the patient.
ऊपर उठा के. नहीं, flat, bed flat.
Now again roll the bed sheet.
We'll have to make bed flat.
Yes, make the bed flat.
Roll. Bas.
Now take the patient slightly up so the head is hanging
Roll. Roll.
from the bed.
Roll करो.
Roll the bed sheets.
On the count of 3, we have to slide patient towards me. 1, 2, 3.
Now rotate the head slightly, gently,
Securing the airway and lines.
keeping the tube in place and IV line secured.
Yes, I'm rotating the head. The opposite side. Okay.
Now the patient can be taken down.
On the count of 3, 1, 2, 3. Securing the airway and securing the lines.
remove the top bed sheet. Now we can show the unproning procedure. So take the bed sheet again and spread it over the patient. Now the team on the ventilator side will roll it outward and the opposite team will roll it inward.
अंदर की तरफ.
Now team on the ventilator side will pull the patient towards themselves.
On the count of three. On the count of three. 1, 2, 3. Slide.
Check for the tube position and IV lines.
Tube secured, ma'am. IV lines are secured.
Now turn the patient at semi-prone position.
On the count of three. 1, 2, and 3.
Again checking the posture and tubes.
Tube secured. Lines are secured.
Now make the patient supine.
On the count of three. 1, 2, 3. Sheet remove.
Remove the top bed sheet and pillows. So the proning and unproning procedure is explained. Now we can know what are the contraindications for proning. So if the patient has facial trauma within 15 days, there is therapy for deep venous thrombosis within 48 hours. Patient is not hemodynamically stable. History of hemoptysis recent one within 1 or 2 days. Patient is ICP is raised, or in pregnant patient we should not prone the patient. If there is anterior chest tube in the anterior wall of the chest, then we should avoid proning the patient. In prone position, CPR is also important. If the patient requires CPR, then we should not delay the CPR to make the patient supine. We should start it immediately over the thoracic spine in the midline along the base of the scapula. And then we can ask for the team. If the team, when the team will arrive, then only we can make the patient supine and then continue the CPR. Otherwise, CPR will be performed in the prone position following ACLS protocol. As per the protocol, we have to perform. There is no other change.
Thank you.
Such a beautiful demonstration for the proning and making the patient supine again. And that was the last practice session for the day. If any questions are there, they are more than welcome.
I want to ask a question to the team. Can you please tell us how does proning actually help in improving oxygenation of the patient?
Yes, ma'am. In supine position, the stomach content push the diaphragm and the heart up, and so the dorsal alveoli get collapsed. So there is ventilation perfusion mismatch. So when we prone the patient, dorsal alveoli get reopened and there is more area for ventilation. So ventilation is improved. So there is alveolar shunting is reduced and better ventilation perfusion is there. Prone position also reduces ventilator induced lung injury because there is more area for ventilation for the same tidal volume. So it will reduce the ventilator induced lung injury. Thank you.
Thank you.
Thank you, team.
Thank you, ma'am.
Before we wind up for the day and say goodbye till tomorrow, I would like the whole team who has taken all the efforts to do these practice sessions for us to join, introduce, and then we'll say bye. So we start with, introduce yourself, please.
My name is Ranpal. From OTA.
My name is Deepak Kumari. I'm a nursing officer in ESIC.
Myself, Vikrant Singh Yadav, nursing officer, ICU. Dr. Yawar Rashid, assistant professor, anesthesia department.
Myself, Yogesh, nursing officer, man OT.
Myself, Sumarani, nursing officer in ICU.
My name is Kuldeep Singh. I am from main OT third floor.
Dr. Mamta Kumari, assistant professor, anesthesia department.
Okay. I am Manju Mishra, assistant in charge of ICU. I am Dr. Megha Soni, assistant professor, Department of Anesthesia, ESIC Medical College, Faridabad.
I am Dr. Rashmi, associate professor, anesthesia.
Myself, Dr. Niharika Grover, assistant professor in Department of Anesthesia, ESI Hospital.
Myself, Dr. Bushra, assistant professor, Department of Anesthesia, ESI.
I'm Dr. Mudit Roshne, assistant professor, Department of Anesthesia.
I'm Dr. Mahesh Kashyap, associate professor, Department of Anesthesia, ESI, Faridabad.
Dr. Anup Raj Gogia. I am professor in the Department of Anesthesia, ESI Medical College. Thank you.
Sir, Beach. Ramesh Nath, ANS, ESIC Faridabad.
I am Pradeep Kumar, OT assistant.
And we have a big team for technical support from Ladal, Mr. Karamveer, Mr. Vishal, Mr. Sanjeev, Mr. Rakesh. And audio visual team is headed by Mr. Ravinder, Manjeet, and John and Shiva. So a big round of applause for the whole team, and thank you participants. See you tomorrow. One more introduction.
I'm Dr. Monica Agarwal, Nodal Officer, Skill Lab.
So we meet tomorrow morning at 10. Yeah. See you again tomorrow. Thank you. Bye-bye.